Yeah, good afternoon. I think we're just about there. Everyone's had a shot of coffee and a bit of light relief, and I've set my timer for 22 minutes. So good to see you all. There's a lot of old faces and thankfully some young faces that I don't recognise in the room. But some of you have been at this for a long time. ABF, I was wondering, what's that? Anything but finance? I don't know, it's activity-based funding. I get it. The topic I'm talking to you about is this. The regions and in fact the consequential changes in the centre of the HSE, and just to give you an update on what's happened to date, where we're at, and what's happening next, and just explain that journey a bit. It's a journey that in effect started in 2017 when Sláinte Care document was published. We had a bit of a hiatus in 2020 to 2022, which actually still continues in the form of COVID at some level, but we're now very actively, and have for the last year and a half, been working very actively within the HSE and across our stakeholders. Department of Health, Sarah is here working with Murish in the department, who we're working very closely with, and also with DECIDY, Department of Children and Equality, who are also funders of the HSE, so that's relevant to us. This is a room, I guess, where weddings take place, marriages. I was looking around seeing the lights. They're too nice just for conferences like this, I suspect. So I always thought of ABF as a sort of a marriage between accountants, doctors, nurses, clinical staff generally, and data people, some of whom are sitting over the table over there. I can see Lorna and Emer, and you know, the analytics that go with that. In a way, this program I'm talking about is a slightly different form of marriage, and stay away from thoughts of divorce and separation. That comes later. But I'm just talking about the good bit here, the embrace, the loving feelings, the affection, all of that. And it's important to remember what we're talking about is a vision that's expressed unusually in my lived career, and in anyone around long enough in the health environment in HSE and predecessor bodies, an agenda that's agreed across all government parties through a report of Sláinte Care published before the Oireachtas. It still drives the discussions today. If you look at the Joint Committee on Health, and you know, if you're not working hard in your various respective roles and you go online and watch one of those committees, you'll find when they're talking about health, they're very focused on Sláinte Care in all its aspects. This is just one piece, but in all its aspects. And it remains, therefore, a common glue that if we behave appropriately, we can work within and move the system forward. And as you know, the agenda is very much person-centred, very much about care coordination close to home where that's feasible and possible. Standards, the role of the centre of the HSE around standards and a commonality of service across the country remains strong, even though the centre will not be operational. In fact, at the moment really isn't operational anymore, except for the services that will be under Pat Healy in National Services. We'll talk more about those, and some screening services under Column. And so, and we've invested heavily in a health and wellbeing approach and a public health approach to healthcare provision, and recognising that many determinants of health are not in the health system. The health system often catches you when the things that determine your health status have gone the wrong way, whether it's salt, alcohol, or anything else that's referenced in the Healthy Ireland strategy. And the core objectives are around aligning hospital and community, so singular leadership for those is the first step, but not the only one. Strengthening accountability, corporate and clinical, supporting population-based approach to service planning, and improving equitable regional investment. And I won't go on there. Sarah will talk more about the population-based resource allocation process, which the thinking piece of which has now commenced. And don't savage her because your part of the country doesn't get enough money. It's not about cake size, it's about cake distribution. So in a sense, it's important to remember that. And it lives comfortably with ABF as a fellow partner, because ABF can be very much used around care acquisition or comparative analysis, or indeed looking at care across care environments. But the PBRA is much more about how do you distribute a cake regionally, if you describe it as a cake. You're aware we're going from 9 CHOs and 6 hospital groups to 6 health regions, so that process is underway, and I'll describe what's happening there. CHI, Children's Healthcare Ireland, is under separate legislation since 2018 and was considered to be a hospital group really up until that point in time and related to in that way, but of course now is a separate legal entity, and its contract will be held in the future by the Dublin and Midlands region, by the region in which it's primarily based, even though the urgent care centre in Conley is across the river in Dublin. And the design principles we were using are those. I find the best way to think about those is put not in front of them or absence of in front of them. And then you go, oh yeah, I get it. That's why you're trying to do that thing. But when the further you go in thinking about how the system should be structured, the more you need principles to go back to say, well, against what metrics or design criteria are we holding ourselves to account collectively? What are we trying to do and what are we trying to achieve? And just by way of update around what's happened to date, those 6 regions were determined in July 2019 by decision of government following papers prepared within the department and interacting across the system. So they're a long time there. Work around the communications and logoing and branding of the health regions. They were initially called, I think, alphabetical names A to F, as the CHOs were one time called 1 to 9. And the 1 to 9 is a horseshoe from Donegal to Dundalk, kind of. The A to F is a horseshoe from Dundalk to Donegal. It's the way I remembered them, but they actually eventually took on names. These have already taken on names associated with geography and the brand HSE. Not the words Health Service Executive. So if you're on the DART or you're looking for a lift down the country and you say Health Service Executive to somebody, they don't go great. You're like, what's their first reaction? But actually the public reaction to focus group reaction when our communications people do it, to the logo HSE is reasonably strong. People feel a sense of connection around that, and that's important. So it was decided to retain that following those kind of engagements. We are transitioning now to an environment where there won't be groups and CHOs, but that'll complete at the end of September this year. And the regional fora, the forums, of which there are 4 in legislation, will grow to be 6. The Department of Health have to propose, and the Minister has to propose some legislative amendments to achieve that, but that's underway and colleagues in the Department are working on that. So the forums will align to these 6 regions. At the moment, there's a crossover. So if you're in Cork, which I was meeting the forum there, you're also speaking to people from Carlow at the moment, which for them it's a big journey. I'm not thinking mileage there, I'm thinking culturally and the mindset. What's happened to date, just a brief timeline. So where we are at the moment, to go to the end of that, is the recruitment has just commenced for the integrated health area managers. So the structure of the country is confirmed to be 1 HSE, which remains a singular legal entity, 6 regions, which exist as subdivisions of that single legal entity, no change in law about that, and 20 integrated health areas, which are subsets of those 6 regions. Those of you around long enough remember we had ISAs at a point in time. I think 17 was the number that were integrated areas. So we're moving back to 20 integrated areas against a set of design criteria that were around population, nature and size, and rurality and distribution of population primarily. And so those decisions are made and that recruitment has commenced. And going back a bit from there, the 6 region chiefs have now been appointed, mostly on the 5 of them on the 4th of March, I think, and then on the 15th of April, Sarah Long was appointed. And they're now looking at how they fill out their deeper structures. And I'll talk about the work that's going on at the moment around those structures. We've engaged a lot with the voluntary sector. I can see representatives of the voluntary system here, Caroline. And we've also engaged a lot with patient representative groupings in this dialogue because other things are happening as this work is ongoing. And so the collaborative forum that the department operates arising out of what's known as the Catherine Day report has reached conclusions around the engagement with voluntaries and opportunities in that area. Patient engagement, there are many fora that operate, but we've met with the representative groupings and produced a document on how we will engage as a system in the future with patient representatives. And the key to us is to say we've done a piece of work on that over the last 12 months. It's the regions that need to implement that. And so we're bringing that to the REOs for their consideration and implementation. The HSE centre structures, I'll speak more to in a moment, but the first view of that Bernard expressed some time back, and that centre structure is evolving coterminously really with the growth of regions because these things are obviously interconnecting. And we'll be in an environment, I think, by September where we have a revised structure in the centre, the main change being it's not operational, barring the areas I referred to earlier. And we have regions that are then the operational apex of the system reporting into Bernard directly. And that chart just reflects those timescales. So the CHOs and groups today report into the regional executive officers, and the intention in the blue, the lighter blue on the right, is that the regions take in their new structure, recruit their new structure from within ourselves overall, and go live on that, complete that by the end of Q3. So that new structure will then be the operational environment for 2025 in its entirety. And there's a lot of work to be done between now and then, and recruitment and advertising and all of that. And just to say, as part of that, we're engaging with National Joint Council of Unions. We're meeting FORSA frequently, and I think we've just received a request to attend the WRC on some matters around these issues. And that'll be an ongoing process, I think, over the coming months. These are the courageous people who've taken on the role of leading the national health system in 6 subcomponents. And I kind of mean courageous unless they're silly, and I don't think they're silly. But it's a heavy burden to carry, to take all of the responsibility for 1/6, or up to 1/6 of the country. Most of the region's populations are between 700,000 and 1 million. The region we're in here is about 440. I think they argue in Limerick, David will correct me, but something around 440,000. But its coherence with the river and mountains and the Atlantic has seen it continue for really right through all instances of change in the health environment as a Midwestern region, and it continues to do that. So Sarah has come from the north, as you know, and Andy Phillips in the south has come back. He's Welsh of origin, but has come back from Australia and New Zealand. So they've taken on the new roles. They are today operationally accountable for the health environment as it operates today in the system. The centre is assisting them with their accountabilities, but is no longer accountable because the CEO has moved legal delegations. I had a legal delegation once myself that just said you're responsible for all that and those of the acute environment, and comma plus NAS. And, in a way, they've all got that kind of delegation, which Grace and David would have had up until the end of, or the beginning of March. And yet they don't have a structure to deliver against that. So they're very reliant on the centre in lots of ways, whether it's in finance, HR, or ops generally in community and acute. They're very reliant on that capacity. Now, to talk about boxes, and these slides are available, so I don't want to pollute you with them too much, but the main thing to notice here is there's a CEO and there are 6 health regions. And the way Bernard expresses that is that the rest of the corporate structure exists to support the 6 regions in delivering what they have to deliver for the population, which are the Sláinte care objectives around access to care and safe care in all care areas. On the left side of that, there's a new director called Access and Integration, which is currently out to advertisement. I think applications closed on Monday, if I'm not mistaken. So hopefully if you wanted to do that, you got your application in. And you can see that's where the main care groups will be retained within the centre. National Services, which Pat Healy is occupying, the names are in that, they're very small, so I don't know if you can see them. I know them, I can't see them. Will include NAS, the National Admin Service. I should say, when you think about the centre of the HSE, I asked the question myself, what is the centre of the HSE? How many people report to national directors? The answer I've been given is 9,126. And roughly 2/3 of that is actually in national services. NAS is about 2,400 of that on its own. So the core piece, the core centre is actually, I won't say relatively small, but it's not any part of 9,126, but it's much more tied into the functions and the operational components of the HSE. And the fact that the largest pieces being retained within the centre are functions where IT would have about 1,000 people in it. Only about 260 of whom will be in Dublin, so the centre itself is very distributed. You have a post there also on major infrastructure, which is to go to tender on the right-hand side. The main thing to note is there's no head of operations. Damien's previous post, Damien McCallion's previous post is gone. There are now 6 Damiens. That's what I think in my head, there are 6 Damiens. I used to say 6 little Damiens. I've stopped saying that because it might be pejorative. There are 6 Damiens in the system. And in a way, it's not unhelpful because anything you would have previously as an engager with the HSE asked of Damien or a director who reported to Damien is fundamentally now mostly a question that would be for a regional executive officer to respond to. And the CEO has some things to the right of himself, which our board kind of encouraged around patients, patient safety, around culture, risk, and Joe Ryan is minding those. Patrick Lynch is in the planning and performance box on the right. So most of the good work in the HSE and in voluntary sector happens between boxes, not in the boxes. It's the interactions between people that make stuff work. And so the question of how in future access and integration, the clinical area and planning centrally operate is an important one, and that's being teased through, and what's its relationship with the regions, and how do the regions operate vis-a-vis the centre in this changed environment. All of that is being teased through at the moment and being operationally experienced at the moment. And that'll be bumpy for a while. And the Department of Health have communicated with us around their thoughts around what this change means and what matters to them in this change. And indeed, some thinking about how it impacts upon them. Let me speed up a bit. The region's executive management team, I should have said in the central one, there's 3 new posts going in finance, HR and estates at the request of the Department of Children and Equality for disability. So they're actually new posts that they as a funder to the HSE are authorising us to recruit and encouraging us to put in place for transparency and visibility of disability resource through the system. And in this level, which is the Regional Executive Officer on the far left, the one disappearing off the screen I'm looking at, is actually a disability post also for that same purpose. But the operations are going from the CEO to the Regional Executive Officer to the IHA heads. So the IHA head is a geographic subcomponent. There are 20 of those, and they're just gone out to advertisement, and they will in effect run all the services that exist underneath them. On the left, you've got the clinical kind of groupings in their structure, and on the right, the support. The design work underneath that, what will finance look like in an IHA in a region? That work has to be undertaken, is being undertaken now, but the answer isn't there yet. It will have to be there over the summer and will involve people both centrally and regionally in terms of working that through. And NAS and estates in the light blue on the far right have people who can link in and not report to the OREO but work with. So NAS have already put in place 6 regional GMs for that purpose. They previously would have had 3. And those disability posts are just reflected in that structure and in that diagram. The real work of the HSE happens in what we're now referring to as integrated health areas. So the hospitals, the community healthcare networks, of which there are 96 in the country, and maybe just to go back to the map a minute, the 96 community healthcare networks build up to the 20. So there's a faithfulness to the 96 units in the primary care organisation as the core components, building blocks. There are 50 to 90,000 population clusters of the system, and the IHA is made up of a number of those. That's the construction of it in population terms. But all hospitals and all voluntary and statutory and all community services are operating within and either reporting into or contracted with the IHA head for that geography. The blue lines are intended to indicate that there will be networks of care that run above IHA and maybe regional, or could in some cases be national. Like there's national trauma strategy, there's national ICU component around that. There's national strategies in other areas that may transpose clinically into regions through clinical directors. Pat Nash has done work with Colin Henry on the clinical governance around this, and is proposing networks of care as a way of providing the glue against which the system operates. Not all services are clinical, so that same principle works for disability, mental health, social inclusion and other areas. The design work we're doing now is to say, what is this piece going to look like when it's structured? So when we talk to the OREOs now, they're saying, how will it operate if we've an IHA head and we've services on the ground? What exists between the IHA head and those services to make sure we're doing what we need to do and that services are being provided to people? And there's a whole layers of structure there at the moment, and service to do with regulation, to do with service provision, and we have to reimagine that on a geographic basis. That's the specific piece of work we've just commenced now. And just briefly on programme governance, I'm reporting to Bernard, and Bernard is clearly reports to the board on this. There's a steering group which he chairs, which I and others nationally and regionally sit on, and includes Department of Health, private sector, not private sector, voluntary sector and patient reps. And then Bernard also co-chairs the Sláinte Care Programme Board. So that board is looking at all of the interactions around the Sláinte Care objectives, and this is one of those. And the department have a unit which Sarah, who's speaking next, I think, and Murish are working within, and we are working closely with them on a daily and weekly basis around these changes, and that's feeding into the department's management structure. And separately, the joint committee keep an eye on us and ask us how's it going, and are we there yet kind of questions, but also some quite probing questions. There's an advisory group, Leo Kearns chairs, that met only the other day, that is advising the minister on how this is going, and they publish letters every now and again about how they think it's going and what the focus needs to be, and they've done that over time. That's a term of reference, and the membership, I won't bore you with that. Future funding models, yeah. someone's trying to help me there on the finance side, saying, well, this is really for Stephen to talk about finance structures and systems, but I'd more go. I won't speak too much to that because, in a way, what we're looking at is a shift in objective that is integrated. So I think ABF views of resource across the way patients are intended and service users are intended to be treated is what's important. And I know ABF, the HYPE data through to the ABF data, the dashboard, which I still look at, and sadly maybe, but it's just I got used to it and it does help. That set is there and quite strong, and I think does allow. I was at the Hip Fest yesterday, only barely, because Carol, my PA, thought the Hip Fest was some sort of rock venue thing. It turns out it's actually the hip process that HPO actually contribute into, and they had 10 years of working as a clinical collective around driving value and productivity. I have 1 minute, Brian, based on my timer. Are we still okay? Yeah. So, and I do think that the use of the finance data within the acutes can be tell a very strong story around productivity and change, and just push out what's there and be open about it and say, where do we go and how do we change? Like if you see a 13% growth in attendances or admissions of over 75s, it's having an effect, and the HYPE data set shows that very clearly. But spreading that to capture the full pathways of care, like I was talking to Martina Queally this morning, she's looking at our older persons and saying, well, I have Vincent's and I have my services in the community, but they're kind of separate and I need to get them together. She actually needs a funding model that also incentivizes the right connectivities and behaviours across that environment. I know she needs technology and structure and processes that do that too, and so does she. But the notion of an activity-based funding or the resourcing tracking the way in which we intend the patient to be treated isn't a bad thing, and I think probably a very good thing. And not doing that is probably a bad thing. There's a red sign. Red's hard to read on green, but I think it's saying time's up. So I'll stop there. The PBRA is something that I won't speak about. I think that's going to be Sarah. So I'll stop, Brian, and thank you for your attention.